I saw this young female in her mid 30s and she started looking for an answer to her daytime sleepiness in her 20s. Her primary care did actually send her to a local sleep clinic and she did end up going through a home sleep test. She was told, hey, you don't have sleep apnea. There's nothing else we can do for you. Her condition just kept on getting worse. She reached out to us. She's like, hey, I don't want to know whether I have sleep apnea or not. What I want to know is, why am I sleepy? Why am I tired? All sleep disorders does not equal to sleep apnea. There are so many sleep disorders. Just because I have one negative test doesn't really mean much. If I'm a person or I'm an individual who is struggling with, let's say, falling asleep or difficulty staying asleep, then home sleep test, unless you have sleep apnea, is not going to be very helpful.
Welcome back to the Hidden Sleep Disorders Show, where we uncover the science, diagnosis, and treatment of sleep disorders that often hide behind chronic fatigue, poor sleep, and unexplained exhaustion. Today, we're talking about something that surprises a lot of people: the fact that a sleep study can come back normal even when something is genuinely wrong. And for many patients, being told their sleep study was fine almost feels like a dead end. But the reality is not that all sleep studies are designed to find every condition, and the way results are interpreted matters enormously. So, Dr. Saini, let's help our listeners understand what is actually going on when a sleep study misses the real problem. It's great to see you as always. I'm excited to hop into this episode with you. How are you doing today?
Doing pretty good. Thank you, Leila. Thrilled to be here. Let's dedicate today's talk to all the researchers and the companies who are spending a lot of sleepless nights and dollars on trying to crack the sleep code. May their research dollars never disappear.
Absolutely, absolutely. So let's hop into it. But before we talk about what sleep studies miss, I think it really helps to understand what they actually are designed to do. So when someone goes in for a sleep study, what is being measured? And beyond that, what is the test primarily looking for?
So, obviously, there are different kinds of sleep studies, and generally, sleep studies trying to measure some sort of physiological signal. For example, the very common ones, for example, home sleep test is generally the most commonly done sleep test. What is it measuring? It's mainly measuring my oximetry or my pulse ox as we know it. And, since we're post COVID era, everybody knows, what pulse ox does or what the oxygen or how it's measured. So that's what they're deriving a lot of the data from. The more detailed studies, they are also measuring my breathing effort, how each time I take a breath in, my chest wall moves. So they're measuring that effort. The other parameter that it measures is the airflow from my nose. So sometimes we have tests where we use a nose cannula. You've seen people wearing oxygen cylinders that's applying oxygen through the nose. So same cannula, we can use that to measure the air leaving or entering my nose. So we're trying to measure that flow as well. So those are generally the typical sort of signals that are being measured from the home sleep test. Now, the in-lab sleep study is a whole different ballgame. It's way more detailed and there's a lot more physiological data. So let's unpack some of that. What is being recorded in an in-lab sleep study? In-lab sleep study has several components. The first one is my brain waves. We call it EEG. And those are the channels to help us determine what different stages of sleep that this individual is going through. So we record their brain waves. Then we're recording their eye movements. And that's how we can tell if someone is going into REM sleep or REM sleep, which generally stands for rapid eye movement. So if I'm not measuring my eye movements, how do I know if I'm going through REM sleep? So that's another indicator that we're measuring. We're also measuring our muscle tone. So for example, in certain stages of sleep, my muscles could be very relaxed. And in others, my muscles could be very tight or clenching, or I could be clenching my jaw, or I could be kicking my hands or legs. And so those are the EMG channels where we're monitoring the muscle activity, or EMG. So, and that's all part of the PSG or polysomnography. It has multiple sleep physiological signals. That's why it's called poly meaning multiple, somno meaning sleep, and graphy means a lot of different graphs. So that's where that word comes from. We're also measuring heart activity through EKG channels or electrocardiogram. So we're monitoring the heart waves. Then we're obviously monitoring the airflow, the snoring. We're monitoring the effort of my breathing through my chest belts, through my abdominal belts, where we're measuring the effort of breathing. So those are multiple signals. So it's actually one of the most, I would say, detailed physiological study that we do in current day and age, and it gives a whole lot of data, a whole lot of information. In fact, we sometimes struggle how to make sense of all this data, and that's one of the challenges that researchers are trying to figure out, to especially now with with AI and whole lot more data processing capacity that we have access to. That's what a lot of companies are trying to figure out. Okay, how do we make sense of such rich data that we're able to capture through the in-lab sleep study?
Absolutely. And like we touched on, not all sleep studies are the same. And patients are sometimes sent in for one type, but another might be more appropriate. So I know you touched on all of those sleep studies, but what are the main types of sleep studies that are available and how do they differ from one another?
So the first one I would say is the home sleep test, because a lot of people are doing it. A lot of companies are advertising for it. If you Google sleep study, you'll probably end up having a list of 10, 15 companies that would like to ship you a device and take your money and give you a report. So those are home sleep tests, and obviously they're convenient and they do have some value. But what I'm noticing in real life is that a lot of our patients get sold those home sleep test devices, or they do these studies, but no one really is there to help them figure out the outcome of those results. Or they might come back negative, and then they get told, go home, there's nothing going on here, which can't be farther than the truth. So that's home sleep test. The other one, like I said, in-lab sleep study, which are several different kinds of in-lab sleep studies out there. So the first one is diagnostic in-lab sleep study, where we're just looking at, okay, what is going on in your sleep? What is going on with your breathing? And we do not intervene, meaning we do not add any kind of treatment during that night, during that sleep study. And then the other version is where we actually try you on some treatment. For example, CPAP titration studies, where we put you on the CPAP and then slowly titrate and figure out, okay, what settings are most comfortable for you? What does, as far as pressure settings, what makes sense? Is it able to eliminate all of my sleep disordered breathing or sleep apneas? Is it able to bring my oxygen levels back up to normal? Is it helping improve my sleep architecture or brain waves? So, all those could be determined through that CPAP titration in lab sleep study. And then, of course, in the CPAP world, there are all different kinds of PAPs out there. So, if I need more advanced versions of PAP therapy, CPAP, BiPAP, VPAP, there are all kinds of PAPs out there. So, then we have to determine which sort of treatment modality it does suit best to my patient. So those are the treatment or therapeutic titration studies that we do in our sleep lab. The other part to this for the in-lab sleep studies, sometimes we do even more detailed tests where we do an in-lab sleep study overnight to kind of see, okay, how does the nighttime sleep look? And then we do what we call MSLT or nap study, where we have individuals take multiple naps throughout the day to figure out, okay, how sleepy you are or how tired you are during the daytime, and then sort of figure out if I'm dealing with rare disorders like narcolepsy or hypersomnia and stuff like that. So these, in a nutshell, are multiple different sleep studies, and they all come with their own set of limitations, their own set of advantages. So you have to figure out one, hey, this is, if I'm offering you a home sleep test, then I better know what are the limitations of this test. When is it going to miss? Are you a good candidate for that home sleep test or not? And sometimes these questions are driven by the insurance policy too. For example, some private insurers, they won't even cover an in-lab sleep study right off the bat. So then you have to take a step approach where you do the home sleep test initially. And if that is not answering or not coming up with right answers, then we follow up with a more detailed in-lab sleep study.
Got it. And I think with all the sleep studies, one of the most frustrating experiences from a patient's perspective is probably being told that their sleep study came back normal, but they're still feeling terrible. They're still having all the same symptoms. They don't feel better. So, how is it possible for a sleep study to show normal results, even when a patient really does have a real sleep disorder?
That's a great question, Leila. So let me give you an example. Home sleep test, for example. And there are newer versions of home sleep tests that are more like, if you've seen Aura Ring or
Hmm.
Apple Watch, those kind of technologies. So they have gotten much simpler. But the little bit more mature home sleep tests or older versions, they used to have belts to measure my breathing effort. They used to have nasal cannula and a recorder to kind of sense what position I'm sleeping in. And it had a pulse oximetry or pulse ox component to measure my heart rate and oxygen levels. And those tests, they're still wonderful tests, but in the right individual. And generally, the home sleep test historically was developed to figure out quickly in a person who has high risk for sleep apnea, which is, for example, if I'm a middle aged guy, I have other medical conditions. I have obesity, I have diabetes, I have hypertension. So I have all these multiple medical conditions that go hand in hand with sleep apnea. Home sleep test is a pretty good test to start with because my pre-test probability, meaning what are the chances that I have sleep apnea is pretty high. For those patients, the home sleep test makes complete sense. But in contrast, I have a young female in their 20s or 30s, and they're complaining, I'm sleepy, I'm tired. And, they're not morbidly obese. They don't have any high blood pressure. They have regular menstrual cycle because menopause changes the impact for women. Menopause pretty much doubles my risk for sleep apnea in women. So that impacts as well. So in that particular individual who does not have such a high disease burden, their risk for sleep apnea is on the lower side. I'm not saying they can't have it. They still can, but the chances that I'm going to find it on a home sleep test are pretty slim. So the home sleep test is going to come back normal because they don't really have a high disease burden. And that's one limitation. And all the people who are doing these home sleep testing through online companies or through Dr. Google or whoever, without a good backup follow up plan, are going to miss out, or they might, unknowingly think, oh, everything is good as far as my sleep is concerned, just because the home sleep test came back falsely negative. So the home sleep test can have pretty high false negative rates. And each test you have to know. And obviously, it's just like, hey, user, be aware that this device that I'm using can easily miss some of these things. On top of that, if I'm dealing with other sleep disorders, for example, restless legs, chronic insomnia, if I'm dealing with dream enactment behavior where I'm dreaming about, fighting and I'm throwing punches in my sleep and hitting my bed partner, those kind of individuals, the home sleep test is not going to capture any of that or not give us the answers we're looking for. Same is true for patients with narcolepsy or hypersomnia. Home sleep tests can give us some information as far as, the trends of sleep, but it's generally not very helpful in that population.
And with certain sleep disorders, we've talked about that certain sleep disorders can be harder to detect through standard testing or harder than others, for example. But which conditions are most commonly missed or underdiagnosed because of the limitations of typical sleep studies?
Let me give you a real patient story. I saw this young female in her mid 30s, and she started looking for an answer to her daytime sleepiness in her 20s. And the unfortunate part in this is that her primary care did actually send her to a local sleep clinic, and she did end up going through a home sleep test. But without really listening to what her main problem was, she was told, "Hey, you don't have sleep apnea. There's nothing else we can do for you. Go home." And fast forward this after 5 years, 10 years of struggling all by herself, then she's like, enough is enough. I gotta find some answers here because her condition just kept on getting worse. Then she started doing some research, and then she reached out to us through our website, mwsleep.com. And in her contact form, she's like, "Hey, I don't want to know whether I have sleep apnea or not. What I want to know is, why am I sleepy? Why am I tired?" And that's exactly, we're talking about today is that, hey, all sleep disorders does not equal to sleep apnea. There are so many sleep disorders, and they present sometimes in a very similar way and sometimes in very different ways. So a person who's dealing with this, they have to understand, they have to learn that there are different tests for different conditions that could be done, and follow up testing just because I have one negative test doesn't really mean much. And that also leads to, the clinical acumen or clinical judgment of the clinician that you're seeing and how they tackle your concerns. I think that's also very important on top of testing. Yes, it would be so much easy if tests could give us all the answers, but in real life, it doesn't generally work that way.
Right, of course. It would be a lot more simple. And speaking about that too, home sleep tests have become increasingly common because they are more convenient and they're less expensive than in lab studies. But what are some of the limitations of home sleep tests, and when can relying on them lead to a misdiagnosis?
I agree with you. Home sleep tests have several advantages, and we use it all the time. In fact, most insurers require home sleep testing as the first step. So it gets done whether people want it or not, whether we want it or not. A lot of time that's driven, as far as coverage is concerned. And yes, it is cheaper, it is convenient, and I can do multiple nights to kind of assess some trends in my patient's sleep. So those are the advantages, but that's where all the advantages really end. And so what are the downsides of home sleep testing? They have much higher failure rate. And then a lot of times patients, for example, a lot of my patients who have memory changes or who have a lot of heart problems, those are the patients who we expect will have a lot of complex sleep apnea, and home sleep test is generally avoided in that population. Home sleep test is not really focused on looking at my sleep structure, looking at my sleep architecture. So if I'm a person or I'm an individual who is struggling with, let's say, falling asleep or difficulty staying asleep, then home sleep test, unless you have sleep apnea, is not going to be very helpful. So the main focus of the home sleep test is sleep apnea. And I would go even further. The main focus of home sleep test is only obstructive sleep apnea. Some of the home sleep testing devices, they pretend that they can diagnose other more complex looking sleep apnea, but they generally don't do a good job in picking those up. But for obstructive sleep apnea, if it's present, then yes, that's a good test. But any other condition outside of obstructive sleep apnea, and there are hundreds out there outside of obstructive sleep apnea, home sleep test is not going to do the justice and just can easily come back negative. So don't assume home sleep test is going to answer all my questions. In fact, even for my obstructive sleep apnea patients, let's say we found out that this individual has obstructive sleep apnea on a home sleep test. We go ahead and treat it. But then they come back and they say, okay, then why am I still sleepy? Why am I still tired, even though I'm treating my obstructive sleep apnea? Then I have to go to more detailed testing in the sleep lab, like a nap study or a titration study to fine tune things and figure out, okay, what else might be going on. So the testing doesn't really stop at home sleep tests. It's really just the first sort of screening method to lead to more questions rather than answers, to be honest.
That makes sense that it would be the first point, especially due to convenience and price, and then kind of use that to see what else is needed. And with the multiple sleep latency test, that's used to diagnose conditions like narcolepsy and idiopathic hypersomnia, but it has to be administered and interpreted correctly. So, what are some of the ways that the MSLT can really produce misleading results? And what do you think patients and clinicians should be aware of regarding that test?
That's a very important question, Leila, because NAP study is also not a answer all panacea either. You have to keep it in context of your patient's life. Here's an example. If I'm dealing with someone who has insufficient sleep, meaning they can easily fool the test by sleep deprivation. For example, one of the things we ask our patients before the day of their NAP test or MSLT is to keep a sleep log for at least 2 weeks to ensure that they're getting enough amounts of sleep going into the test. Why do we do that? Because if you go into the NAP study being sleep deprived, you can easily come back falsely positive. So the test may look like as if I have narcolepsy, even though the reason for that test to be positive is because I was only sleeping for 4 or 5 hours versus sleeping 7 to 8 hours, which should be normal for me. So that's one important thing, that if I'm planning for a nap study, I have to prioritize sleep, not just the day or night of that nap test, but several days going into this test, almost for 2 weeks. I should not be sleep deprived. The other limitation that we commonly run into is the use of antidepressant in our patients. So what does that has to do with sleep study, you would think? So the problem is when I have a person on antidepressants, and 99% of them will suppress my REM sleep or REM sleep. And that's what the medication, it does. That's their impact on our brain waves. So, for example, in narcolepsy, I'm trying to find if you have abnormal REM sleep. Now, if I'm already taking an antidepressant medication, that water is already muddy. So I cannot find those brain waves that I'm really trying to find on that sleep study. So we have to have a honest conversation with our patients who are taking these medications, and sometimes we run into cases where you cannot safely take them off these medications. And then you have to document that this NAP study was done while patient, because the results can be skewed from that. But generally, the protocols, they guide you that to ensure that you give enough time to the patients to get themselves or wean themselves off of these antidepressant medications to get clear answers, to get clear results. So that's another important thing to remember. The third challenge with MSLTs we run into is that a lot of times these are young patients. They've never had any sleep studies done in the past inside the lab. And it's a fairly long, lengthy test, right? You're spending a night in the lab and then you're spending a whole day in the lab. And a lot of, especially I see that in my younger female patients, that they have a lot of anxiety around the test, and anxiety is not good for sleep. So then, even though I'm dead sleepy or dead tired all the time, but the day of the test, my anxiety, my apprehension is so high that I can't really sleep. And that leads to misleading results, not because that patient isn't sleepy, it's just because of their sleep environment or the nature of the test. So that's another challenge we run into, which it's not such a hard fix. Generally, once they've done it once, we repeat the test in few months, and then generally it's much better. But it still is something that we run into quite often in our practice in real life. The other challenge that with MSLT is that there is sometimes, for example, let's say someone did a NAP study 5, 10 years ago, and it showed that it came back negative, for example. It does not reproduce well if you repeat it. Generally, the most reliable tests will bring up the same outcome, bring up the same results when you retest the same individual. So if I have a patient with narcolepsy, if I with the NAP study, ideally, I would like that every time I do a NAP study, it should arrive at the same answer, right? That's what we expect from a great test. But the challenge with MSLT is in that same narcolepsy patient, that NAP study could come back negative one time and it could come back positive the other time. So then it gets super tricky if, let's say, I'm not paying attention to their clinical picture, their clinical history, and not taking into account their previous study results. I might come across a negative sleep study, and then I might discount those symptoms and say, hey, are you faking this? And then I'm questioning poor patient and not really being helpful at that point, right? So that's a big challenge. And I think there's a lot of researchers who think about this and want to somehow correct this limitation of the NAP study or MSLT. And I'm pretty sure in our lifetimes, we're going to see some improvements in testing or maybe a completely different test that would help us understand these conditions more than what NAP study can achieve at this point.
Absolutely. And then with sleep medicine, with all the tests we talked about, sleep medicine is not just about reading the data from a machine. So, how does clinical judgment and the experience of the interpreting physician factor into whether a sleep study leads to the right diagnosis or not?
Is super crucial. Data reading AI or LLM models can do that way better than I can ever do it, right? So, but that doesn't mean they're going to be able to replace a physician's knowledge or acumen. Yes, they can replicate some of that stuff, but the clinical skills needed to come up with the right diagnosis, and not just the right diagnosis, but then to come up with right solutions to treat those conditions. And they're paramount. So you have to have a good understanding, have to have a lot of experience under your belt, have to have a lot of training and basics, basically clinical skills, good listening skills, good examination skills. All those are paramount to come up with a good solution for our patients. Because yes, and that's the downside. If you're just following the data, you're easily going to assume that, hey, the test was negative and that's all we got. And that's going to let down a lot of our patients. And I'm hoping with this discussion that we try to bring this to everybody's attention. That don't just assume just because your Apple Watch says you don't have any problems with your sleep apnea or the home sleep test shows negative doesn't mean everything was or is being captured.
Absolutely. And like even what you just said about young women having those tests that their anxiety gets higher on that, that's something that I feel like clicks as a clinical perspective that, for example, AI or just a machine of data can't really replicate. It's that clinical knowledge of those specific things that really tie into the whole, experience beyond just what data can give you.
That's right. And these data processing systems, I would call them, they have made our life simpler so that we can focus more on our patients now. Because, hey, I'm not, doing clerical job anymore. I can crunch that data easily. But then how do I put it in perspective for the patient in front of me? That requires listening, that requires understanding, that requires their goals, that requires the understanding of their life situation, the challenges they face, and all of that. You have to process that in terms of coming up with a good solution for them, because hey, naming a disorder or disease is much simpler versus then actually doing something about it and changing their lives in a much more holistic, much more productive way so that they can go about doing what they really want to do and not be burdened by these conditions. And that takes, a lot of willpower, a lot of understanding, and a lot of experience.
Absolutely. And then for someone who has already had a sleep study and they, for example, have been told everything's fine, but they're still struggling with that exhaustion or poor sleep, what would you recommend as the right next steps and how should they advocate for themselves in that scenario?
I think you're absolutely right because they do have to self advocate. Because sometimes we get told, okay, there's nothing wrong on this test, then that's all we can do for you. And at that point, obviously, everyone has access to a lot of big databases now. Everyone's Googling stuff, and not even Google now. There's OpenAI, all kinds of AI models. I would say the most common scenario we run into is people doing this commercial home sleep testing at home and then just using that as a watermark, so to speak, like, okay, my home sleep test was negative. It must be that I don't really have any sleep problem, even though, I'm being challenged by it day in and day out. The other scenario is where, hey, if you already have access to a sleep clinic, then you have to ask them yourself and even the care team there is that, hey, are you just focusing on sleep apnea or are you looking beyond sleep apnea? And I think that's an important question that without really offending anyone, I should be able to ask my care team that is this test only focusing on sleep apnea or will I be getting any more detailed answers from this test? And I think that would give you a lot of ammo, a lot of actionable stuff to understand. Because a lot of times, majority of these testing programs will try to rule out or rule in sleep apnea, but then they just leave it at that. They don't really go any further trying to figure out, okay, what is causing your hypersomnia or what is causing your exhaustion or fatigue.
And even with that, there's some limitations of current sleep testing. So the limitations of current sleep testing are well known within the field. But what advances are being made in sleep diagnostics that really may help catch more conditions that are currently being either overlooked or currently being missed?
That's a loaded question, Leila. Let me try to break it down. Actually, there's multi-pronged advances happening. The field of sleep medicine has really taken off, which is, very heartening to see. So some of the advances that has happened over last few years, the home sleep testing has become even more convenient. And we're trying to add more physiological signals to these home sleep tests just to capture more information and see how we can come up with more, not just sleep apnea, but other disorders too. On top of that, we're also trying to utilize machine learning in crunching all this data that we're capturing from in lab sleep studies. So we're trying to create models that would look at my in lab sleep study data because it's super rich data, right? We earlier in the talk we talked about how all these different signals, EEG, muscle signal, heart signal, oxygen signal, breathing signals, all of that data can be crunched. In fact, there is a model that is researchers are actively working on that can sort of act as a prediction tool to come up with almost 100 plus medical disorders or medical conditions that a person could be at risk of just from that sleep night data. So that data is really full of information, and with all this new technology, I think the next frontier really is to harness that data and figure out how we can predict some of the future things that might be happening to our patients as we go.
Absolutely. And Sleep studies are often seen as the definitive answer when it comes to diagnosing sleep disorders, as we touched on. So, what is the most important thing that you want patients to really understand about the role of sleep testing and getting the right diagnosis?
So, key takeaway for all the listeners would be one, there are different kinds of sleep studies and they serve different purpose. So, I think that's the most important key point, I would say. Home sleep test is generally good for people who are already at very high risk for sleep apnea. And when I say sleep apnea, mostly obstructive sleep apnea. And that's where the home sleep testing currently is limited to. Yes, there are different companies who will make you believe that there's a whole lot more to it and they'll present all these beautiful looking reports, but generally the data is not as robust when you put it to test against the gold standard in lab sleep studies. So then the second one is to also realize that even the in lab sleep studies, there are different kinds of in lab sleep studies. There are diagnostic in lab sleep studies, there are treatment based in lab sleep studies, and then we have to tailor or customize based on each patient in front of us as to which study makes most sense. Sometimes we get calls from our patients and they're like, hey, why can't I just go ahead and do a sleep study? Why do I need to come in and talk to you in person or over a telehealth visit? And that's the reason is because I need to understand what sort of sleep disorder I might be dealing with, because that will change the testing that I might be ordering. And unfortunately, a lot of the sleep testing, home sleep testing, is being sort of pushed or driven by the insurers, which we all know they're all trying to just push the cheaper tests, whether I need it or not, to save some dollars. But in the end, they end up paying more because one, they do the home sleep test, that doesn't give you any answers. Then they end up paying for the in lab sleep studies. So there's a lot of, duplicacy happens. But we also live in the world where insurers think they know better than the patient and the doctor themselves. So we have to deal with that bureaucracy as well. But still, we're in this together. So as long as we have the confidence of our patients, we keep plugging along.
Absolutely. I think that's so important. And I really did not know that there were so many different sleep studies. So it's been very interesting to learn about that. And for people that are struggling with all these different feelings of fatigue and brain fog and all these things that go along with excessive sleepiness, for example, it's really informative for them to know that there are not only all these tests, but all these ways that can really help to diagnose what they're struggling with. And before we wrap up this episode, is there anything else that you wanted to add in or say that maybe we didn't touch on yet?
So there are, so many sleep tests out there that I didn't even cover because it's impossible to cover all the testing. But we did touch base on the home sleep test. And then, sometimes it just get used. I'm starting to see folks who are doing these newer tests without knowing their limitations, and they're thinking, oh my gosh, how come my CPAP therapy is not really working, or my home test shows this or that, and get really worried, and that impacts their sleep. To those folks, I highly recommend to talk to your sleep care teams, talk to your sleep physicians, talk to your sleep clinics, and make sure you get more detailed testing done in order to understand what's really happening. Because there are false negatives on those home sleep tests, and there are some false positives on those home sleep tests. So don't just rely on one testing.
Absolutely. And I think that today we really learned that a normal sleep study result is not always the final word, and that the type of test ordered, how it's performed, and how the results are interpreted can all determine whether a real condition gets found or if it gets overlooked. So, if you have been through a sleep study and you still feel like something is wrong, don't give up. The right evaluation with the right specialist can make all of the difference. And really understanding how these diagnostic tools work and where their limits are puts you in a much stronger position to really advocate for your own health. So if you found this conversation helpful, be sure to follow the show so you don't miss future episodes. Great speaking to you as always, Dr. Saini. I always learn so much. And to all the listeners, thanks for listening. Make sure you follow and share the show. And thanks for listening to the Hidden Sleep Disorders Show. And we will talk soon. It's a pleasure speaking with you as always, and see you later.